Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with my friend Borjor. How are you doing?
Fine, Dennis. Really good. Getting along. A bit croaky in the voice, but fine.
Good. Very good. So today, our last podcast we did on austere dentistry, and today I'd like to take care of one of your other specialties, which is maxillofacial surgery. Actually, if you wouldn't mind, would you just kind of do a quick introduction?
Yeah, sure. So I did my master's in Max Fax in India, and I did my fellowship in head and neck surgery also in India. Then I taught Max Fax in India, in Oman. I did mobile surgical services in New Zealand. I did a maxillofacial rotation in UK. But nowadays I'm just a general dental practitioner. But we try to teach what we learned by working in austere environments and dealing with these injuries through our hands-on workshops. So that's a rundown of it.
Perfect. So, I'm extra glad because you actually have some experience working in austere environments and having to deal with these injuries in a more practical way. So just jumping right in, and if you don't mind, I'd like to just kind of run through this, kind of like a March type algorithm, right? So step number one is just hemorrhage control. There are so many vessels in the face and head that even just a minor cut can cause an enormous amount of bleeding, and it's visually very disturbing, right? So, if you don't mind, I'll just start at the top of the head and kind of work my way down. These bad scalp lacerations or even avulsions, like, how do I stop this?
Yeah, so basically you're right. It's got a lot of blood vessels. So if you start from the scalp, you got either a massive hemorrhage, which is arterial, which you see it pumping out, or a delayed slow ooze, which is venous, you will categorize it as a part C of your March algorithm. But then if you don't come back to it, and if your transportation period is long, you will face the consequences of ignoring it. So not only you have the March as is, like you're losing blood rapidly, losing blood slowly, but also this blood loss is going to affect the patient because he's gradually getting hypovolemic. Secondarily, it's going to affect by blocking his airway, his breathing, and thirdly, it is going to cause edema. So basically, if you're looking at scalp, rapid blood loss due to loss from the temporal arteries, gradual blood loss from the venous arteries. If you're looking at mid-face fractures, you're talking of a lot of hidden blood loss, which is going to compromise his airway. And then you're looking at the tongue, you're going to look at a massive blood loss, which will secondarily lead to edema. So it could immediately compromise the airway, or it can give rise to blood clots. And therefore, if you do your intubation slightly later on, you could dislodge the blood clots and then cause an airway problem. If you look at penetrating neck injuries, they will again either cause problems due to immediate rapid blood loss or compression in the formation of a hematoma. So essentially, it's not just blood loss for the sake of blood loss, it's blood loss and the complications related to that blood loss which take place. So you've got to be really, really aware of that. So obviously, if you're looking at a vigorous blood loss, it is in the M part of your algorithm, and you got to control it. Now, there are three essential ways of controlling bleeding. One is by direct pressure, one is by indirect pressure, and one is by balloon tamponade, or a combination of that. So the TCCC very often goes in the combination of the first two, which is a direct pressure and an indirect bandage, which is going to put indirect pressure over all that. So if you're looking at the scalp lacerations, the problem with scalp lacerations is that you cannot assess them really well because of the degree of hair and all that in that area. That's one problem. The second problem is you can't figure out how deep they are because of the degree of undermining. And the third problem is it's hard to figure out whether it is an open scalp laceration or a scalp laceration involving an underlying structures and not involving an underlying structures. So if I was sure that the scalp laceration had not gone through the skull and it is just an outside or a closed scalp laceration, I could very often use something like a hemostatic gauze like Celox or Celox Rapid. Pack it with that and put indirect pressure over that and possibly put a triangular bandage holding all that in place. Or we have this netting gauzes, which is a tubular net, which is used on burns victims, which you essentially put on top and hold it in that. But I would go one step further. If I was going into a place like a cave rescue, because we started teaching search and rescues also, if I was going to put a triangular bandage, a pack and a triangular bandage to hold it in place, and I know it's a good fixed bandage, I would reinforce this intervention with a flexi surgical strap also on top of it, or duct tape also on top of it. Because whenever you do intervention and when you shift the patient, there's a horrible tendency of intervention and bandages shifting when you're shifting the patient, which is much more hassle than to repeat it, change it, tidy it up, than if you make it bomb-proof right at the start. So that is what I aim to do. Now, if you have an open scalp laceration where it has gone through and through the skull, exposed brain and dura mater, it is advised, have a drink of water, not to put direct pressure onto the brain tissues. And in this case, Dennis, you were talking to me slightly earlier of another technique which you use. And maybe you can share us with that one, because I'm not too familiar with that one. What I would do is I would not put Celox or any hemostatic gauze, because the research is not there. What happens when the chitosan granules contact brain and dura mater? I would just put a saline gauze pack gently in, put a wide surface pressure pack so there's no direct pressure onto the open skull, and then hold it on together with a triangular bandage and then reinforce it with a duct tape or a netting dressing. But you had another dressing which you were talking about.
Yeah. So, there's not, any one or two vessels that feed the scalp. It's just a network of capillaries, veins, and arteries. So what I learned is essentially you take, a rigid tubing, okay, and that can be an ET tube or any other type of rigid tubing. You essentially make a loop with it, and then you would you could use duct tape or any kind of tape or some kind of wrap to make sure that stays connected. And then you would put that over top, and then you would secure that with your dressing. That way, the whole of your loop, there's no direct pressure going in, okay, but there is direct pressure going around the laceration. And so then you're compressing the vessels, without directly putting pressure on the injury itself.
Fantastic. It's like circumferential pressure, just gripping the whole outer bit. Fantastic. That's really neat. And I haven't seen that. I'd love to see that in action. Then if you come to the ear, if there is a lot of bleeding around, you do not want to put an obstructive dressing on the ear. So what you do is you just I always like the rule of 3. I'll use it very, very often. So the first dressing, I loosely put inside the ear next to the antihelical fold. Second dressing, I would probably split into 2, put it in back and front. Third dressing, a loose dressing on top. And then I love the barrel bandage. I use a barrel bandage a lot. But in a normal fractured jaw, you put a barrel bandage centering along the lower jaw. Here, I'll put a barrel bandage centering along the ear, which could then go across. You put just a cross knot here, so it's gone across like that. Then it comes across just above your eyebrows, back of your head, and then you just put a square knot directly over the knotty ear. That holds the dressing in place. Then we come across the cheek. Now the cheek and the lip are 2 places where I use a technique known as counter pressure. The problem with a big blast injury on the cheek is that you can't put any pressure on it. Like I was once in Worcester and there was a through and through knife cut going through the cheek, and the paramedics could not put any pressure to stop it from bleeding. Again, I use 3 bandages. So the first bandage, a nice big one, I put inside the mouth between the teeth and the cheek. The second bandage could be a hemostatic bandage, like a Celox rapid bandage, which I would put in the cut laceration. The third one is a big one, which goes then outside. Then I put pressure on it for around 3 minutes because it's pressing against the teeth here. And then I hold it again in place by using a barrel bandage. But now the trick is, what if it's a prolonged field care situation and the patient is stuck with you for a long time? So the twist in the tail is that the first dressing I put in, I won't just put a normal gauze dressing. I'll put the gauze dressing in a Ziploc bag, in a plastic bag or a cling film. That is what I put in, so it won't get wet very fast. Then the second and third will follow, and then the patient can actually feed themselves by tilting their heads on the left, on the non-injured side, backwards, and allowing food and fluid to go into the patient's mouth to hold it in place. So the same counter pressure exists even with the lip. If you got a lip laceration going through and through, and you can't stitch it up, you have to put a dressing in to hold it in place. The first dressing will go inside in the gap between the cut lip and the teeth. Now, if you used it before, you will notice that you have to be generous with this dressing. So if the laceration is here, the dressing must extend 2 to 3 teeth on either side, a lot of distance on either side, and also vertically it should extend above the sharp edges of the teeth. Then the second dressing goes in the laceration, third dressing outside. Why? Is because then finally we put an elastic bandage pushing the lip against this inside dressing. It tends to ride up, and that is why you need sufficient length and width of the dressing inside the mouth. So when it rides up, it does get pressure onto the intraoral dressing, which will then reduce it from bleeding. Then you come to the neck. We're still in soft tissue, so you'll come to the neck. And the neck, again, is a combination of packing. You can just put a normal pack in. You can, for a penetrating neck injuries, open penetrating neck injuries, you can put a Celox pack in, a hemostatic pack in. You can put outside pressure or the TCCC formula, or putting pack inside and an external pressure pack which is going below, or you can put a balloon tamponade. So the tricks with these is that if there is penetrating neck injury and you put a direct pressure pack in, you put another pressure pack outside, and you hold it for 3 minutes, and you're putting an elastic bandage which is going across like an Israeli bandage or something like that. The trick to do that is, when you're putting the bandage, tell the patient to lift, or the casualty to lift the contralateral hand up, because your elastic dressing will go deep in his underarms, and put it nice and tight. So when they put this arm down, the pressure on the opposite side back is even more, pressing it down really, really well. And I would still reinforce with duct tape or a stocking, because you don't want it moving. So how do you do a balloon tamponade? Is that you use a Foley's catheter if you have one. So you can use a 18 to 20 French Foley's catheter. Now the advantage of using a balloon tamponade technique is that it is simpler. Secondly, it prevents or reduces hematoma formation. And thirdly, it prevents tissue collapse in that area. So if there is a penetrating neck injury, bleeding, you slide the Foley's catheter in gently. You can wrap a bit of hemostatic gauze also in it to give it added pressure. So you push it in, you gently fill it with 10 ml or so saline, and then what happens is that you will notice that the blood starts pouring off the lumen of the Foley's catheter, because at the end of the day, it's a catheter. Don't get distracted by that. Let it bleed. Because if you get distracted and you lose the pressure here, the balloon has a tendency of bouncing back out. So the next thing what you got to do is to put a few stitches into the skin to hold the balloon catheter in its place, and then you can tie off the lumen to stop the retrograde flow of blood through the lumen of the Foley's catheter. And I would suggest even then put a bit of a pressure dressing around it just to make it bomb-proof. You always have to make it as strong as possible so that in the medevac it doesn't shift.
Yep.
Then you come to the bone bleeds. So bone bleeds are upper jaw, lower jaw, simplest way. So the lower jaw is essentially, if a fractured lower jaw is there, it'll bleed. There's a bony segment which is moving around. Is it important? Actually, it's not, because bleeding from lower jaw isn't much. It can be irritating. Over certain stages, it can get life-threatening. It can keep going on, but very, very, very rarely. It is irritating because it'll affect your airway. So essentially, if you pull the bony fragments together and hold it together, the bleeding will reduce or stop. So you can do it a few ways. You can pull the bony fragment together, push it against the intact upper jaw, and hold it together by putting a barrel bandage. Or you can take a little wire-like substance, put it with 2 teeth away from the fracture line. You push the wire from inside or cheek side to the tongue side, 2 teeth away from the fracture line. You push it out from the tongue side to the cheek side, and just as simple bridle wire. That's what it's called, a bridle wire, which holds the fractured fragments in place and will reduce the bleeding considerably. The problem I've noticed is not for the airway, it's not so much as bleeding. It's 2 things. It's displacement. Of course, the jaw gets displaced, it'll block the airway. But the most irritating thing is blood causes a lot of saliva. That just adds a lot of volume in the mouth. And that I find probably more irritating than anything else. In the case of the upper jaw, you cannot put any pressure. That is a problem. It's really hard to put pressure in, especially in closed upper jaw fractures. In this case, we always follow the vertical structure technique. So we build a vertical structure, and this vertical structure must rest on a foundation. So it rests on the clavicle. So that is your base of the vertical structure. And then you put a semi-rigid C-spine collar here, and that will support your lower jaw. Even if it's fractured, it'll support the lower jaw. If you don't have a semi-rigid C-spine collar, you can make one by using a SAM splint. And then, so now this is supported. Now you got to support the hard palate. So you put bite blocks in. If you don't have bite blocks, you can use a plunger of a syringe or the full syringe. I prefer a plunger because if you put the full syringe, it tends to keep rolling out. So plunger is triangular and it's held in place. And then you fix your midface by using an inflatable catheter. They are hard to get and they're expensive. The best ones are Epistats, which hold the maxilla. So basically, if you inflate it, what will happen, it'll be pushing the upper jaw down, but the upper jaw cannot go anywhere because it's blocked by the bite block, which is blocked by the supported lower jaw. So that is how you support the midface. Now, the trick, if you do have an Epistat, which is the best thing ever, is that you inflate it, or inflate it together at the same time. You can't do one, then the other, because the maxilla or the upper jaw will just cantilever. So you have to do both at the same time. If you don't have an Epistat, I mean, in most of the global south, you might not get an Epistat. Where you are, you might not get an Epistat because the Epistat can only be used in the nose. However, Foley's catheter is useful in many other places, and you might easily get a Foley's catheter. So if you're using a Foley's catheter, you would use a 14 to 16 gauge Foley's catheter, slide it in, then you inflate it by around 10 ml, and then you gently pull it so it's snug in your postnasal space. Then you take a 1/4 inch ribbon gauze or a Celox gauze, a hemostatic gauze, and you pack the anterior nasal space. Now, when I was teaching to the medics in Myanmar about using this technique, they said, but we don't even have Foley's catheters. I mean, they're just too expensive, even with us. So then you use the technique, which actually I use most often in India. Because when I was in India, Foley's catheters were expensive, Epistats didn't exist. So in those days, we used to just buy a pass a simple suction cannula through the nose and then make our own post-nasal pack. So you take a 2/4-inch ribbon gauzes, tie it on a normal gauze. So you've got a gauze with 2 ribbon gauzes sticking out. Then a third ribbon gauze we tie to this gauze and it sticks out in. So these 2 are the umbilical ones. So when the catheter goes through the nose and comes out through this mouth, you take the 2, the umbilical ones, tie it to the end of the catheter, then you pull the catheter out through the nose. So these 2 go from the mouth, comes out through the nose, and then the gauze pack has gone behind in the postnasal space. You take your finger, push it behind the soft palate, tuck it into the soft palate. So now you got those 2 threads coming out from the nose, 1 ribbon gauze coming out through the mouth, and then you just tie it together against a sort of a swab pack so it doesn't press too hard on the nose. So that is your post-nasal pack, and against this you can put an anterior nasal pack. So just as I keep saying, for a mid-phase bleeding, you can control that by a simple SAM splint, plunger of a syringe, and gauze. At the end of the day, you can manage that. Like a fractured jaw, you can sort of manage it by simple wire. Any wire will do. You don't need any fancy wires. So you can get down to basics and manage it with basics.
Good, very good. Now, can you back this up? I mean, obviously, venous bleeding or arterial bleeding, TXA, tranexamic acid, that will obviously help. What about bone bleeding? Will that also help stop that?
Bone bleeding, it won't help that much. Approximation is the best way to stop bone bleeding. But if you look at the bone, like a lower jaw, so the lower jaw is here. At the end of the day, the bone bleeding will come from a little channel, sort of just a third above the lower border of the mandible, which is the inferior alveolar blood vessels. And that area, if you approximate, it'll stop. If you crush also, it will stop. So it's a lumen where it's pumping blood out of it. The rest, the lower jaw bleeds, but not as much. So that is the main area where it comes from. In the upper jaw, of course, the maxillary artery and all that at the back. But another place where it generally can come from is in the roof of the mouth, just next to your first molar tooth. Here, that is a greater palatine artery. Sometimes that gets cut and bleeds, and that can be obstructed. I mean, we've done it in the past by putting a little sterile matchstick or a wooden stick inside, and that'll plug the bleeding there. But it's rare, it's not that often, and it's small. It can't be mega life-threatening, so it's not that important. We keep saying mandible, more than bleeding, it's the pain which is the main issue. Lower jaw is the pain, which is the main problem.
Yeah. And definitely, I think super important and something that people forget. You need to have pressure both inside and outside coming in. I think probably just kind of basic instinct, just mash down on it. And especially if you have mandibular fractures or maxilla fractures, you don't have that rigid support of the bone structure anymore. So essentially you're just mashing on broken bone.
So common. You just see them taking the mass battlefield dressing, the big ones, and just whacking it in. But it's so simple. Instead of taking the big one, just put one before and then sandwich it in, and you'll achieve much better results. That's so true. It's a reflex action. You see a big wound, you just want to pack it in, but you forget that there's nothing at the back to stop it coming.
Yep, very good. So kind of moving on our March algorithm, we get to airway. So, I've seen a lot of, pretty horrific airways, whether it be just trauma on the battlefield, whether it be attempted suicide. And I've seen them where they can manage themselves if you would just sit them up and let them lean forward. But I've also seen it done really poorly, either by forcing them backwards so that they lay on the litter like they're supposed to, like God intended. Or they start losing consciousness and they're not positioning themselves. And I think people forget, they're not only bleeding outside, they're bleeding inside, like you mentioned, and they're starting to swallow blood. And I know that blood is very irritating to the stomach and it's not going to last really long. So how do I predict the need or what is the appropriate airway maybe early? What is the appropriate airway going forward whether I need to just let this guy position himself and we can get things sorted out. Maybe I need an adjunct, an NPA, or just manual holding up, keeping his airway open. Or do I need to progress to a definitive airway, whether it be intubation or cric? Like, how do I sort this out in a reasonable amount of time?
Yeah, that's really a good question. So basically, the facial injuries have plus points and minus points. The minus points is it's vascular, it'll bleed, it'll swell. The plus point of a mega facial injury is it's really easy to get an airway because you can see the airway when it's blown off. You can literally see the airway tubes. Very easy to intubate, very easy to go through. So that is the mega facial injuries. Whereas, of course, which are not that common, hopefully, but the other ones are. So basically, if you come across a patient, the first thing is that by using the tripod position, if they can manage it, they're maintaining their airway. So you got to remember the back of your head, this is temporary. Their sympathetic drive can only maintain them for that long. Sooner or later, things are going to go down south. So you got to sort of start getting ready. And depending on then it'll depend on the operator factors is like, what is your experience, what materials you have, what you're comfortable with, and how many operators are there. So why, and of course, peripheral factors will depend on how soon the Medivac is going to be there. Is it a permissive environment? What sort of materials and equipments you have to work with? And of course, the patient factors, how good the patient is to deal with all of that. So therefore, you will have a different way to deal with it than me, because you would probably be more comfortable with going for a surgical airway because of your depth of experience in it. Whereas for me, I would be more comfortable for managing the local area to avoid a surgical airway as much as possible. So therefore, it'll depend on those factors. So you have to balance all that out. So let us go at what are the definitive airways. So definitive airways is, of course, for yourself, it's a surgical airway. If it is a short drive or a short time to the hospital, it's for intubation. You got a tube past the vocal cords, that is a definitive airway. He's not going to aspirate any blood. So you can't use any LMAs or something like that because there's a lot of fluid in that area. So if you have an experience to do a definitive airway, if you can manage it as a planned procedure rather than an emergency procedure, you can follow your Miss Maid's algorithm, follow everything properly and do it properly and nicely. That's it where you would go. For me, I would try to get hold of my teammate who's probably as experienced as you and says, listen, if things don't work out, I might have you to do a creaker to do it, or I might have to do it. I'll tell somebody to prepare it, but my main focus will be, how do I prevent his airway going down south? So therefore, first thing I will do is, why is his airway going to be compromised? It's because of physical obstruction by blood flow, obstruction by saliva. So therefore, I will look at it. If it's a lower jaw, the lower jaw is going to be displaced by displaced lower jaw. Because the tongue is attached to the back of the lower jaw, it's fallen backwards. It's obstructing his airway. He's bleeding. Can I pull the lower jaw forwards and upwards, tie it to the adjacent part of his broken jaw, thereby control his bleeding, thereby stabilizing his tongue, and therefore can I hold it like that? Do I have suction to maintain this patient? That will also depend on it. Do I have enough medication to maintain this patient? That will also depend on it. Again, upper jaw, if probably one of your medics would be around, instead of splinting the upper jaw, they would probably go like, airway is going to get compromised. I'd rather just get the airway sorted out. And of course, the patient is still going to bleed. So you have to do that also. But that is not his or her comfort zone. So they will sort the airway out first. Then they will go on to splinting the midface. But I will go to splinting the midface first and then keep the airway as a backup. So there will be a lot of factors going into my consideration of what I'm going to do.
I mean, I absolutely understand difference in comfort levels and differences in technique, but I guess why are you more comfortable managing, let's say, the midface and then worrying about the airway versus somebody like me who's going to panic, strike him, and then do the midface?
You got enough depth, experience in managing airways. I've got enough depth and experience managing midface fractures. So it is just, the operator factors, the comfort zone where we are, and our degree of specialization in that field. So you would probably do a Crico much faster, much better than I would. I would be doing probably the mid-phase splinting and managing the mid-phase far quicker, better than you would. So that is the thing which will play into the whole algorithm of my thought process.
Okay. So just a quick scenario. I have a patient just like you described. I cric him, and I have probably this giant mess of bandages trying to hold everything together, and I deliver him to you. Are you happy?
First thing I would do is just check and make sure your Crico is proper and it's done and it's working well. Next thing, I would wipe and hoover the whole area up to make sure what are the injuries. So basically, whenever I see a patient, even if it comes from you or anyone else, of course, if it comes from you guys, I know it's been well assessed. But if it doesn't, I do like a 5 sweeps. So first of all, I do a general sweep, make sure because facial injuries are so distracting that you can easily miss out something more important. So I just make sure there's nothing I'm missing out, which is there. That's first thing. Secondly, I do like a vision sweep. I just look through what's happening in the patients. So basically, I check that there is edema, is there any bleeding, laceration, any cuts related to the ear, nose, mouth, chin, neck. So I just check all that up. Is there any major deformity, which I pick out immediately? Then I do a verbal sweep. If the patient can speak, I ask the patient, where does it hurt the most? Is there any problems in his hearing, in his vision, in his breathing? Is there any problem opening or closing the mouth? Is there any recent change in the way the teeth are meeting? Then I finally go into a finger sweep where I put my fingers around the patient. The first thing I generally land up doing is a visual acuity test to make sure that this vision doesn't deteriorate, and then check for any sort of a deformity around him. I also try to make sure that I check the nose, that there's no any septal hematoma, which I'm going to miss out. Then check for any numbness around the face. And finally, I look into the mouth and check if there's any like soft tissue lacerations, cuts, bruisings, hard tissue, staph deformity, anything like that. So I do a quick evaluation. After I've done the quick evaluation, I know what I'm heading for. First thing I try to do is to remove any foreign debris or anything which could obstruct his airway. Next, all my attention will be geared on to control his bleeding, control his fluid at the start, so that it makes everything much more stable. Then I know what I'm doing around him. So I'll get a hoover in, a nice suction in, probably grip the anchor or just use the normal tube of the suction, clean that whole area up, make sure any loose fragments like teeth are taken out, and then I will format a treatment plan. The treatment plan will be a primary treatment plan and a secondary treatment plan. The primary treatment plan is if I can just hold his bony fragments together, splint his upper jaw, support his lower jaw, then I've just stabilized his whole thing, and then I can get some breathing space to format a good plan of action, get some good investigations done, where I'm heading for, and then the fixation will generally go from superiorly to inferiorly to stabilize everything in the top and work my way down.
All right, very good. Yeah. So we've mentioned like the Bartlein dressings and different techniques for hemorrhage control. Just moving a little bit farther down March algorithm to see, somebody bangs their head or they cut their head on some metal or God knows what else. But you get a lot of like venous bleeding. Okay, and it can continue and continue and continue. We talked about some of the dressings and different techniques as far as pressure goes, but I've definitely heard of, just throwing big loops or staples or the IT clamp that grabs hold of it and squeezes everything together. I guess, what is the thought process of just reapproximating, even if it's just loosely, not perfectly, about closing that laceration?
Yeah, so that would depend upon the environment. So if it's a permissive environment, if your Medivac is going to be delayed and it's going to be a long time, depends upon your transport platform, how many operators you have, and how many casualties are there. So once you stabilize that, so I keep saying, if you're doing nothing, then you're missing out something. That's one thing. Secondly, the most irritating thing for people coming for a Medivac is hanging around for you to complete some complicated task, because they want to come, grab the patient and move. So if you can balance, like, okay, the Medivac is going to take a certain amount of time, and you've just finished off all the rest of the stuff, and now you're on C, then because the Medivac is going to be prolonged, or for example, if you are in Africa and you're going to transfer the patient, it's going to take half a day to get the patient, then it will be clinically negligent not to control the venous bleed. Okay?
Yeah.
So therefore, it is so simple. If you got some local anesthesia, which is fantastic because it numbs the whole area up, especially dental local anesthesia is even more brilliant. You do not need any diathermies. All you need is a nice thick sutures with a nice big needle, and you go through, take a nice deep bite, a really deep bite. And then if you're comfortable with suturing, if you're not comfortable with suturing, take a deep bite and put interrupted sutures. Don't try to do any fancy suturing. Nice deep interrupted sutures works very well. If you are comfortable with suturing, then you can give a continuous suture. You keep wrapping it around. Even better, you can give a continuous interlocking sutures, which really hold that whole area in place. But now we got these nifty staple guns, which are about that small. And if you're doing stapling, try to get a big, deep bite when you put it in. So if you have a tissue holding forceps, like Atkinson or something like that, you grab it with a tissue holding forceps, approximate it as well together, and put some nice deep bites in, and that will hold the scalp wound together. But don't just stop at that. Okay, so you put staples, you got the scalp wound together, put a pressure dressing on top of that, because there'll be a lot of undermining on either sides. You'll land up with a nice big hematoma below that area where there's still oozing going on. And I've done that mistake a couple of times. So once you put it there, put a pressure dressing and then hold the pressure dressing firmly in place. If it is nose, if your nose, you have complications of the nose, of course, your septal hematomas, septal abscesses, and through nasal lacerations. In nose, don't take big wide bites because the nasal skin doesn't move much. So therefore, you will have to take a smaller bites in. So if it is a nose, I would put an intranasal pack in as a support, put that cut bit of nose back on top, and if the Medivac is not going to come for some time, then I just hold it together by a few small stitches rather than a deep one, because it doesn't hold it in. So just put a few stitches in and then put a pack on top to hold it in place, because you just about got the nose on, it's resting on the intranasal pack, and then you have got a dressing and a pressure dressing on top holding it all in place. That comes to my fundament of making things bomb-proof for your Medivac.
Yep, perfect. Also, kind of moving off, venous bleeding control, like fracture kind of stabilization. We mentioned, the mandibular. You can use a supporting wire. You can wire the jaw together. We talked about using a C-collar, whether improvised or specific, to help stabilize both the mandible. But Lefort fractures, specific, Lefort 1, Lefort 2, Lefort 3 actually going to eye socket. Are there any different, I guess, techniques? We talked about building kind of that structure that's sitting on top of the clavicle. We talked about nose packing, but do you tackle each one kind of separately, or do you just, if he's got a facial fracture, I go to the nose packs and the C-collar?
Yeah. So only problem is, so we don't tackle Lefort separately, because nowadays it's all complex. It just gets united into one big mush.
Okay.
So if you do want to check, you check for any movement of the maxilla. So basically you take your fingers, your thumb and index finger, and you grip it on the bone above your molar teeth or on the bone above your anterior teeth. That is with your dominant hand. Your non-dominant hand holds the scalp of the patient or the forehead of the patient, and you try to give it a movement. And if there is movement, then there is a mid-face fracture. So in the mid-face fracture, there's generally all mid-face fractures can be dealt with in around 10 to 14 days. So there is no hurry to deal with mid-phase fractures. So when is there a hurry to deal with mid-phase fractures? One, as you correctly said, if it's bleeding and compromising the airway, that's one. A second is all to do with your vision and your eyes. So if there is a retrobulbar hemorrhage, optic neuropathy, white orbital blowout, where basically patient has a difficulty in moving his eye, there is no subconjunctival hemorrhage, but patient is feeling nausea, vomiting, because his orbital contents are trapped in like a trapdoor fracture, then these patients need urgent attention. So that is separate. Okay, so let's just look at your other part of your midface, bleeding and airway. Now, why is the airway affected? Because the midface is a crumble zone. The body is really clever. It's got brilliant crumble zones. So if a midface is hurt or hit, it goes downwards and backwards. As it goes downwards and backwards, it obstructs the nasopharynx and thus the oropharynx and compromises the airway. So that is why. Secondly, it causes an airway problem because of the amount of bleeding which takes place. Okay, so if it's a physical displacement of the upper jaw, then probably I will really miss you, because you will need a surgical airway pretty soon for that patient, because it's not that easy. So you'll read it in the textbooks that if your upper jaw is pushed downwards and backwards, then you can pull the upper jaw upwards and forwards, thereby opening the airway up. Unfortunately, it isn't that easy because it gets stuck in your below your cheekbones, in your zygomatic prominences here, and it doesn't move very well unless if it's a floating upper jaw. This is one article by an Italian, and it's not even translated in English, where he uses suction drains. He puts suction drains through the nose, comes out through the mouth, and he uses that as a grip to pull the upper jaw upwards and forwards. We tried that, and it actually does work really well for upper jaw osteotomies. So you can do that to open the airway, but in these cases, you probably do need a surgical airway because it's really hard to do that. Then the other thing was, like, of course, you do nasal packing, which exists, and for orbital blowouts or retrobulbar hemorrhage is, of course, you got a 2-hour window whereby you'll have to deal with them totally separately as it exists. But that doesn't affect the airway, but you will lose your eye otherwise. Yeah.
Yeah. Right now you're talking about lateral canthotomies?
Yeah, lateral canthotomy and cantholysis, just to relieve the pressure from within the eye. And it can happen, and the way to diagnose it is that, or the relatively simple way to diagnose it, unless if it's very obvious, is you get relative proptosis. You just check the adjacent eye, and also you get, it'll be hard to pull the eyelids open with your finger. So that's another thing. If it's hard to pull the eyelids open with your finger, get suspicious. And the last one is what you can use is RAPID, which is rapid afferent pupillary deficit, whereby you just shine the light into the affected eye, then the affected eye, the pupillar will be dilated, as well as the opposite eye. You have to put all these three things together with the degree of injury, and you put all the factors together, and then you can come to some sort of a diagnosis with it.
So thankfully, I've never run into a retrobulbar hematoma before, but what I was taught, at least, is that the vision is going to collapse from the periphery towards the center. Is that common? Is that a very late sign?
Yeah, so visual acuity, that is why we said always do a visual acuity test at the start, but it doesn't necessarily happen that way. It is not a rule of thumb. So if you look at retrobulbar hemorrhages, there are various ways which you can diagnose it, but it might or might not have that at the start. And we know that the 2-hour period is where we got to get it done. So the earlier you diagnose it, the better. It's like with everything, the more you wait, the more easier it is to diagnose it. Like we were talking about, like, because the bruising doesn't start till later on. Once the bruising starts, you know it's an easy septal hematoma. Even in the eye, once it's definitely set in, you will then complain of patients' eye vision collapsing. Not necessarily in the way you said. It can happen. That is a theoretical way. That's a typical way. But not everyone follows the typical way for it to happen.
Okay. So definitely when it comes to that, just visual acuity, eye movements, I'm imagining those muscles are going to potentially either be trapped or affected in some way. So their eye tracking ability is going to be reduced, pearl, and just the ability for them to open and close their eyelids.
Eyes. Yeah, that is why I say, like, if we get distracted, what's happening in the mouth, we forget to do important things outside on the face. So that is why I always try to do visual acuity at the start. So basically, if you have a visual acuity, it doesn't take long to do. Can the patient read, can count, see your fingers, movement, and light perception? So if you just tick that off, that's good that you haven't forgotten to do that. It's very easy to get distracted in facial injuries. Similarly, with septal hematomas, it's very easy to forget to have checked that. And I think the most dangerous, or the one septal hematoma which you can miss, is a early unilateral small septal hematoma, because what happens is that they are small, they're pink, and they're on one side, and it's very often your deviation of the cartilage gives exactly that same appearance. So all you have to do is to rely on fluctuancy, take an earbud and check whether it's fluctuant or not. That's one thing. And secondly, the patient will say, I never had a nose block there before. This is the first time this has ever happened. So again, it's combination of your symptoms which helps you reach the diagnosis. And all these things have to be treated earlier. You treat it is better, but it's harder to diagnose it early, easier to diagnose it later on.
Yeah, absolutely. Now, mentioning that the face is essentially a crumple zone for our heads, I imagine if the patient has suffered enough force to have a mid-face fracture, that's enough energy to cause a head injury, a TBI, whether mild, moderate, severe. But like, you cannot get a proper head injury class without the classic signs of battle sign or raccoon eyes. So when I bang my shin into the coffee table, I don't get a bruise, immediately.
So true. Yeah.
How long does it take to actually get these, classic signs?
So basically, let's go to the battle sign. Yeah, it was a surgeon by the name of Battle. That's how the whole terminology came about. Is when you, for those who don't know, when you hit your lower jaw, very often, that's where the whole sign came about. When you hit the lower jaw, again, the body has defense mechanisms. So to prevent your jaw joint from going upwards into the middle cranial fossa, the jaw joint is actually tilted. So it actually breaks below the jaw joint to prevent that happening. And that doesn't always work. So the jaw joint can go backwards and upwards and crack the middle cranial fossa, or you could have a middle cranial fossa fracture for various reasons. So basically what happens is there's bleeding in the mastoid area, but like any other bruising, it takes at least 24 to 48 hours before coming. And even after 24 hours, it's not that evident. After 48 hours, it's probably more evident. And I did see quite a few of those in Malawi, and you had to wait a decent amount of time before you got the textbook's picture of bruising behind in here. So what will cause suspicion to you? It's, again, as we keep saying, it's a mixture of things. What was the direction of injury? What is the patient complaining of? And what can you see? So if the direction of injury and there is a chin laceration, patient complaining of pain in front of the ear, and you touch and there's a lot of pain on palpation in front of his ear, that's it. And if you look at his ear, if there's bleeding inside his ear, if there's CSF fluid coming out from his ear, then you got to get really suspicious that something's bad's happening here. How do you make out of it? CSF fluid, it's like it's clear, it's not shiny, it's thin, it's transparent, it doesn't clot. You can use a dipstick, or you can have advanced lab techniques, which you probably won't get where you are. So yeah, you got to be careful of that. And the other one was raccoon eyes. So raccoon eyes, you get it again because your muscles are not attached to the bone in this area. So blood tends to collect either from the facial injury or from the forehead injury as the blood goes down. Again, that will take a bit of time before it actually happens, 24 to 48 hours, even longer. So basically, if you see it, it is the first thing you'll get is puffiness around the eye. and then check inside the eye whether the earlier thing which you'll get is subconjunctival hemorrhage, where you cannot see the posterior boundary, and the patient might complain of difficulty in moving his eye, and of course, check the visual acuity. So now, if you have bilateral periorbital bruising, periorbital ecchymosis, or raccoon eyes, there's possibility of having a full mid-face fracture and, of course, head injury. Or if you have a unilateral one, then it's very often caused by the fracture of the cheekbone. So if it's quite nice to know, if it's bilateral, you're looking at the full mid-face fracture. If it's unilateral, you're looking at a cheekbone fracture. And that is why it's very important to check the visual acuity at the start, orbital eye movements at the start, so you know what is your baseline before you go anything further.
Perfect. Is there anything else that you think that we really need to know when it comes to facial trauma, maxillofacial trauma?
I think, yeah, because recently we had a lot of chat in the WEM chat box, and that was the phobia of medics and even doctors in pre-hospital medicine. When they're faced with a mid-face fracture, they don't want to push anything up the nose. And basically, if you look at the literature, you only have to be scared or worried about anterior central fractures for that to happen. Okay. And if you look at the research, there's a guy who did research called Rosen, who did a research, and he did 86 intubations in facial traumas, nasotracheal intubations. Not a single one entered the cranial fossa. There is only 3 patients in history where it's registered or reported that stuff went into the middle cranial fossa. So therefore, if you're doing a mid-face splinting, that is one part of your splinting. So you should not be worried about pushing things through the nose. So why do we keep stressing that when you put anything through the nose, you put it through the inferior turbinate, inferior meatus? So when you push it in, you piggy the nose, you go through the top lip, just a little bit of the nose, and then you go downwards towards a soft palate or towards the earlobe in that direction downwards, because you got to get it below the inferior turbinate. So I was asked, if you're not that worried about it, why do you keep stressing on that? And if you look at rapid rhinos, if you use rapid rhinos are not bothered. They say just slide it through even the middle part of the nose and it should work. But we say slide it through the inferior turbinate and inferior meatus. The reason is not that I'm worried that it'll go up into the middle cranial fossa. I'm worried that when you push your liquid, because epistats use liquid to inflate it with, whereas rapid rhinos uses air. When you use that, the pressure, if he's got a fracture in the nasoethmoid, with your balloon blowing up, you're more likely to push these bony spicules up into the middle cranial fossa. So we're not worried about the air. What we are worried about is that your balloon pushing bone up in that direction. So that is why we say go through the nasal floor, use 3 landmarks, go flush along the nasal septum, flush along the nasal floor, and parallel to the hard palate, because you would probably know it's hard to get your landmarks when the face is blown up. Yeah.
Yeah, absolutely. And also you wanted to mention one of the teams that you've been working with, Team 5. So if you wouldn't mind, just tell me a little bit about that.
Team 5 Medical Foundation is this fantastic group of ex or past or vets from the American Special Forces. So the vets from the American Special Forces, the medics, have created this charity which a few, like 8 to 10 of us go in a very, very remote area where it is impossible for the locals to travel for any medical care. So bad that they don't have money to travel. Like if they get toothache, they just live with that toothache. So we travel to these areas and we run medical and dental camps for these local populations. But not only do we do that, we also train the local people on how to manage or increase the knowledge in dental and medical and in ultrasound fields. And we also train medical and dental students who come with us in this field. So just building up on their knowledge. So it's American Special Forces Vets charity, which I'm lucky to be a part of. And it's a fantastic organization. Thanks, Dennis, for bringing that up.
Yeah, no problem. So how do I find them? If, say, I want to support them or maybe potentially join them, how do I do that?
Or if you Google Team 5 Medical Foundation, it's a really good website. It has all our videos from the various trips which we've done. So in the last year, we've gone and done very similar, really remote trips to Nepal, Guatemala. We've done to Chile, Colombia, and we're going to go to Peru in the near future, where we'll train the Peruvian special forces and work on the Peruvian ship, and then go by helicopter to different areas to run camps in these remote areas.
Perfect.
So it's a fantastic one. Thanks for that.
Yeah, thank you. Again, I always appreciate you coming on and highlighting everything that I don't know, right?
Oh, Dennis, and I pick up equally as much from you as you me. It's a pleasure talking to you.
Pleasure. Have a good day.
Cheers.
That's it for today's podcast. Be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.